All right, awesome. Well, thanks for joining us at the tail end of SAM here. Um, this is only a 20-minute didactic, so hopefully we'll have time for questions. Our email addresses are in the chat if you have questions later that we don't get to, or if you're interested and want to talk more. So we will be talking about the intersection of behavioral economics and shared decision making. And here are our disclosures. All right, next slide. So we're going to start with a case to sort of try to make this applicable and relate to sort of what we do on a day-to-day basis. My work is in shared decision-making in kidney stones. And the background of shared decision-making is often that if you give a patient information and good communication, you will together come up with a good decision. So let's talk about what this would look like. So let's pretend this gentleman is a 35-year-old male with no past medical history, and he comes in with 2 hours of severe right flank pain. And he's afebrile, and he's got normal vitals, and he gets a little bit better with Toradol, but he's still vomiting, and he still has pain. So you give him some Zofran, you give him some morphine. He looks more comfortable. You re-examine his belly. It's non-tender. You do your bedside ultrasound. You see some mild hydro. He's got 20 red blood cells in his urine, and otherwise his labs are normal. Clinically, he's improving. So you don't need a CT scan, but certainly many clinicians in the United States would order a CT scan. So you decide, because you could get a CT scan or you could not get a CT scan, to have a shared decision-making conversation with him about the risks and benefits of a CT scan. Because you believe, like I did, that if you give people enough information, they make good decisions. But the background or the point of this lecture is that maybe that's not always true. If that was true, why do we have so many smokers? Is it because they don't know the dangers of smoking? So we know that behaviors and decisions are not always about information. So what we fail to realize, and what is sort of my concern within shared decision making, is that although we hope that information will lead to good decisions, there are these ways that we all get biased or nudged, and the patient comes with their own biases. So that's sort of what we're going to talk about here. Next slide.
All right, so I'm going to cover the science of motivation and what we've kind of learned over the last 20 or 30 years and how this can be used to help make better decisions. So, I think the first thing, and whether it's smoking or talking about radiation with a CAT scan, is we make the assumption people don't know, and that if we just educate people, this will change their behavior, and that's sort of been the solution. And then this has evolved to, an assumption, or kind of part of this assumption is that people are rational and can make, really good calculations, weighing the risks and the benefits, for their own personal situation, and make the decision that's in their best long-term interest. And we try to aid this in shared decision-making by collecting really good data, presenting, very finely detailed risk data about the risk of a CAT scan, for example, or design a delivery system that requires, the perfectly, cost of a copay to change behavior. That's sort of classical economics. And what we know is from the combination of applying behavioral insights and studies from psychology to analyses of economic behavior is that we now people are predictably irrational, and their decisions are affected by things like present bias, framing, social context, emotion, many other cognitive errors and biases. And that by better understanding these things and designing around them, we can have better behavioral design. So if you think about some of the foundational work in this space, and I think a lot of people know this, but how does our brain actually work, and how do we work as ER physicians? So we have two types of thinking. So the first is system one thinking. This is your automatic, intuitive, emotional, and heuristic based. You walk into a room and you immediately recognize a patient is sick or not sick. But errors can arise from this type of heuristic decision making. Quickly look at a rash and you say, okay, that's scarlet fever, but you miss important clues that would tip you off. That's actually toxic shock. On the other hand, there's slow and system two thinking. This is where you're kind of stepping out of yourself and calculated, conscious, logical, rule-based thinking. You apply a decision rule to a certain situation, like the heart score. But this is not good to always be a system two thinker, because if you admitted every patient who had a heart score more than 4, you'd be providing a lot of low value care that's not aligned with patient preferences. And so if we think about, and you can go to Wikipedia, and there's categorization of over 160 different types of cognitive errors and biases that are sort of all interrelated, that you can map out different scenarios in which decision making doesn't always align with best long-term interests. You can see that there's a lot of stuff to work around. I'm going to focus on just a couple of these things. So the first, and I think we all intuitively understand this and we see this, but just to name it, it's is what's called the hot-cold empathy gap and present bias. This is the tendency to not understand how visceral factors such as pain drive preferences in a current state that cause people to think in short-term goals that are very different probably than their long-term preferences. This is nicely highlighted in the AM consensus conference and shared decision-making. And sort of a prerequisite to even engage in a conversation about shared decision-making is that you have to alleviate pain or the fear or anxiety that a patient is experiencing so they can get their mind straight to even make a rational, even close to a rational decision. All right, so second thing is that we tend to overweight small probabilities and underweight large probabilities. This is part of prospect theory. This is what won the Nobel Prize in behavioral, for essentially behavioral economics from Amos Tversky and Daniel Kahneman. So I'll talk about a couple of these things. So things like probabilities under 10%, or certainly lower than that, tend to loom larger in people's minds than sort of high probability of something happening. So the typical example is, this is how the lottery works, right? Everyone, there's basically a, almost impossible chance of winning the lottery, yet lots of people use it. And that's why you see bumper stickers like this, a lottery attacks on people who are bad at math, but you keep on getting drawn to it. Sort of thinking about it in a shared decision-making context, you might think about the P-Carn head CT rule, lots of great data. The chances of having something in the brain that it requires action is really low for kids older than 2 years old if don't have altered mental status or skull fracture. But when you start discussing these things at a bedside, and you might be tipped to getting head CT for these things, even though the risk is only about 1% or a little bit less, and you're kind of hemming and hawing on that risk. But what we kind of ignore is that the risk of being fine is 99%, and we sort of weigh that 1% risk much larger than the 99% risk. And this is a nice paper if you want to dive into this more on probability inflation and how that leads to low value care. All right, so another concept is loss aversion. This is part of prospect theory as well. And this is the tendency to value losses more than gains. So if you ask people what gaining or losing $10 feels like, the $10 gain feels like $10, but losing $10 actually feels like losing $20. And so there's all kinds of ways that you can use that to frame things. But I sort of think of this when I look at the decision aid that's put out for using stroke for TPA. It kind of depends on your interpretation of risks and how you want to frame things. If you frame things as like a 20 or 30% chance of improvement, that I don't know how that's going to play against going like a 3% chance of going from your current health state to going worse, with small probabilities, and the loss of let's just say that you're fairly neurologically intact except for a minor stroke deficit. That fear of going to a devastating neurologic state can be extremely influential. So it's really susceptible to how you present this information to patients. Then there's status quo bias, and this is kind of default bias, is that people tend to stick with the status quo because change from the status quo is perceived as a loss. People take the path of least resistance. We showed this in a study that we did when we went from having no default for the number of tablets that you write for an opioid prescription to changing it to setting it a default of 10, and basically without any education or intervention in our ERs, that it doubled the amount that prescriptions that went out the door for 10 pills. So setting the choice architecture and defaults can be a very effective strategy. Social norms and what's called the Lake-Wobbegen effect. This is the concept that behaviors are shaped by perceived social norms, but we often misestimate how we're doing relative to others. This comes from Garrison Keillor, and he said, like Wobbegen, all children are above average, which obviously can't be true. And when we apply this to medicine, this is a nice study by Michael et al. In Academic Emergency Medicine, which found that if you underestimated how much you prescribed, how much, if you thought you were prescribing a lot less than your peers, but it turns out you weren't, and you're presented with that comparative data, it was very influential at getting you to move more towards the social norm of your group, and it reduced the amount of pills prescribed and dosages prescribed for opioids. And lastly, recency bias. I think we all know this one. This is the tendency to overvalue most recent information because it's salient and fresh. I think this really played out with the Johnson & Johnson vaccinations, getting paused for rare instances of clotting. I don't know about you, but when that came out and a woman who came in with a headache after her vaccine came into the ER, I ordered my first CT venogram in a long, long time looking for that. And so you're reacting to that recent information. And this is a study here that when ER physicians in Florida were sued, that they started almost doubling their resource intensity in terms of their workups for patients immediately after getting sued, even if that lawsuit was frivolous. And so it's a reaction to recent events and changing practice. So in response to our predictably irrational biases, like what can we do about it? This is the famous book Nudge. It was actually supposedly called Libertarian Paternalism, but the publishers didn't like that. And, an editor there suggested the word nudge, so they went with that, and that's what it's become. And kind of two concepts. One is that we should pay attention to the choice architecture. This is the physical, social, and psychological aspects in the context in which we make our decisions. So like just how the EMR is built and what choices are presented are highly influential in good ways and in bad ways. And nudges are any aspect of that choice architecture that alters someone's behavior in a predictable way, but doesn't forbid any other options. So what the default orders are in EMR. And so it's always better to nudge people in good directions than in bad directions. All right, turn it back over to you.
So putting this all together, let's think about sort of how this affects shared decision making. So this is sort of the very basic overview of shared decision making. You have two reasonable options, and then there's this process that is shared decision making. Next. And so you've got these biases that affect multiple different places within shared decision making. And then you have nudges that potentially can affect multiple different places of the biases. And it's important that the nudges not be coercive and still allow choice, because that's sort of what the definition of a nudge is. It's not actually taking away choice. And it can counteract these biases and help align the options with the patient's preferences and values. Next slide. So looking at this, in the context of the case we had. Let's see the biases and talk about what nudges we can use. So we always use CT scans. So that is a perceived norm. It might be misperceived or it might be real. And it's also sort of a status quo default bias. This is my default. I always get a CT scan. I don't think about it very much. I missed that API last week, so that obviously is recency bias and maybe some loss aversion. And this, well, what if I have kidney cancer on behalf of the patient? And that, of course, in a 35-year-old male might be sort of this overemphasis on these very, very small risks, that this is very, very unlikely. If it looks like a kidney stone and it talks like a kidney stone and he's 35, then it's probably a kidney stone. Next slide. So looking at that, we can think about sort of what nudges are appropriate for these biases. And we can look at the nudges at different levels. From an ED system design, we want to make easy algorithms so that you take off a cognitive load and they're following algorithms, and they also perceive this as the default. You want order sets that don't automatically default to CT. You want to use peer comparison within radiology. I don't know how many of you guys know where you are in terms of high CTers versus low CTers. I don't know, other than what I see at sign out, because we don't have any auditor feedback. And then, like this study that Kit spoke about, we want discharge orders that have pre-filled numbers of pills that are consistent with what the patient actually needs for the disease process based on science, as opposed to just what I'm used to doing. And then for the patients, possible nudges are really how you frame your conversation. So if you say something like, well, for someone healthy and young like you, we usually wouldn't bother getting a CT yet because the stone is likely to pass on its own. So you're setting a social norm that this is what we usually do, this is the default, even though there still is a choice. Or we could say, either option is fine with me, but if you're feeling better and you have a doctor you can follow up with, it probably makes sense to avoid the time, radiation, and expense of the CT now and save it for if you really need it. And that concept of saving the CT for later, you get at sort of loss aversion. You don't want to use up your CT now because you might really need it later if you're not getting better. Next slide. So when we think about shared decision making, this is a little bit more of the details of the process of shared decision making. We want to present the options, we want to explain the consequences, we want to check for understanding, ask about preferences, and then help people make a decision that makes sense for them. So let's talk about where the nudges fit in specifically there. Next slide. So under options, we could present one of the options as the usual option. That would be a way to sort of get a nudge in there while still allowing choice. Next. When we explain the consequences, we know we should probably minimize the small probabilities because they're going to get overweighted, and emphasize these benefits, keeping in mind that people have a hard time with future benefits because they're really in that status quo, like present bias. They focus on what's going on in the present time. So if your goal was to decrease unnecessary CT scans, you might want to focus on the fact that, like, if you decide not to get a CT, you get to leave now and nothing else really changes, as opposed to like, oh, well, there's this future benefit that's a little bit less tangible. Next. When we check for understanding, that's a good time to look at what people's biases are. Personally, we see a ton of pro-CT biases where they came in with that feeling that the CT meant they would get better faster, which we know isn't true. So correcting and clarifying some of those misconceptions. Next. People at this point sometimes start to express a preference, and if you feel like that preference is value congruent, I really think I should get that CT scan because actually I'm going on a cruise in 2 weeks and I probably need to know whether I'm going to pass this stone, or if I'm going to need a procedure, I'm going to need it sooner because of the cruise, blah, blah. You're like, all right, that's probably okay. You're making that decision for a reason that makes sense. But if they don't know what decision to make, then you're going to help them by understanding how the decision fits with their values and preferences. Next one. And that is often saying something that helps the patient see themselves in the option. So, knowing what I know about you, this option might make sense because you have good follow-up, you can come back later if you need to, or, I see that you're super anxious and maybe this will help, and that sort of thing. Next slide. So our last slide, and we'd love to take questions and hear comments, is on the ethics of this. And a few studies have actually looked at this, looked at the perspectives on using nudges. And the general idea that's come out of the literature that I've read is that the motivation of the nudge is what's most important. If the motivation of the nudge is in the patient's best interest, then it's ethical. And if the motivation of the nudge is not in the patient's best interest, they're trying to sell them a drug, then it is not ethical. And my own research supports this as well. Our patients really do want physicians' expertise. They want people's opinions. They want to know what you think makes sense for them, knowing them. And so withholding your opinion is not what they want, just for the purposes of having, unbiased shared decision making. So in general, having that nudge in there is ethical and makes sense. I don't know how much time we have for questions, but I think we have a few minutes if people want to ask any questions or make any comments.
Can I ask a question?
Please.
Hi, yeah. My name is Rachel Solik. I am an attending at University of Michigan. And I'm really interested in this question about shared decision making regarding potentially like deferring treatment for STIs because we don't know the results yet in like specific populations. And so I've tried to make this more of a clinical policy because I feel like there's a lot of like reticence and perhaps academic or maybe also in the community settings of like doing things unless they have like policies to support them. And when I brought this up, this idea of like, well, they could have shared decision making, and like if it seems like it's an appropriate person, like you can offer that. And there was just like oh well, like what does this mean, how do we like do this? And I felt like it just required too many like variables to have to spell out that I was just like, forget it, fine, just do all the things and I give up. And I'm just wondering if you have any like thoughts or tips about how when you're trying to like make something that seems a little bit out there, a little bit more streamlined, how you incorporate and talk about shared decision making, given that there's so many variables that you can't like say ahead of time. I'm like, I don't have to like describe all of medicine for you.
So I think that you're really onto something by making it a policy, and physicians have said that a lot. Shared decision making makes people nervous if it's not the local standard of care, but if it is the local of standard care, people are much more comfortable engaging in shared decision making. So if you had a little algorithm that said like, do you really think that it's chlamydia, or you think maybe it's, do you know what I mean? Like high suspicion, low suspicion. High suspicion, just treat them. Low suspicion, ask them these 3 questions, like make it a really clear thing. And then I don't know if you guys send scripts right to their pharmacy or give them the scripts, but creating some little thing that makes the shared decision making really easy for the physician. So it's like, you know what, just tell the patient, you're going to get a call in 2 days. You can start these antibiotics or you don't need to start these antibiotics. But I think just like you were saying, taking down all the barriers is going to be figuring out what those barriers that people have and simplifying it so that it's the path of least resistance sort of makes sense. But I can see that people have a hard time with that. The other thing is to draw the analogy with ear infections. And I think people are doing this a lot. Like ear infections don't need antibiotics. So they do this wait and see all the time. And it makes parents feel better because the parents get the script. And you're like, you know what, give it 24 hours. If they're still febrile and fussy, start the antibiotics. But start Tylenol and ibuprofen now. And if they look good in 24 hours, give the antibiotics. Parents seem to be very happy with that. And I think that clinicians can grasp that. So maybe drawing that analogy for people.
Is that something that at your site for kidney stones you guys have created, like a specific policy that incorporates certain decision making? Oh, sorry, I don't know if I was muted.
Sorry, my internet was unstable. Say that again.
Oh, I just had a follow-up question. So at your site, since you've done so much awesome work about kidney stones, have you guys created sort of like a clinical policy internally for your departments regarding like shared decision making?
We have not, because we have an ongoing randomized controlled trial. So we are not telling people what to do because ideally we're enrolling people in the study. But I think that would help. Other questions, ideas?
If no one else has a question, I have another unrelated question. Is there like, I've seen a lot of I feel like potential research out there about like apps and different ways to like educate and engage patients in this. Is there like great overall evidence on like efficacy of these and whether people will use them? Do you feel like that's like where the future of SDM is going in terms of that? Or is that a bit more of like it might work, but it's not actually feasible kind of a game?
Do you mean the efficacy of sort of decision aids, of things that help?
Yeah, I guess I'm talking about decision aids.
People engage in. I mean, each decision aid sort of,
I guess.
Feasibility. So, I mean, each decision aid has sort of gotten tested separately, and most of those studies show efficacy within the study. But it does require, I mean, it's an implementation problem for every single decision aid. And so there are health systems who have made it a thing that here are the things that they do shared decision making for, and here are the resources. To my knowledge, very few emergency departments are as evolved. And for the most part, it's like, okay, we are really good at shared decision making in this area, but we don't necessarily use these decision aids. I think that there's a lot more shared decision making going on than we have decision aids for. It's a lot more like, let's talk about admission versus discharge for this dizzy patient. No decision aid exists for that, but we still do it.
It's like a quick follow-up would be that, I think we're really focusing on the problem when there's like two sort of reasonable options, right? And it kind of really depends on someone's like preferences about what risk they're willing to take. I think and that's sort of a little bit less where nudges are applied. I think we sort of typically think of nudges as like, okay, we have this evidence-based treatment that we need to scale up, and implement across ER. So like I would think like, buprenorphine for patients with opioid use disorder, and how do we encourage providers to do that? We know that it's a good thing, and so that you want to use behavioral design to sort of think about how are you going to get people to use this. That's the more typical thing, and can be very effective at as an implementation strategy to sort of think about nudges and behavioral economics in that. This is a little bit different, and I think really the value is more in understanding, if you're going to be presenting patients with information on risks and benefits, just understanding the cognitive biases that they may have, that you may have, and how that affects things. And I think if they tell you what their preferences are, you can sort of frame information in a way that helps them make a better decision that's sort of aligned with the way that they're thinking.
Sounds like we need to do an implementation of shared decision-making didactic next year.
I would love that. Do you have any thoughts also about like regarding this choice architecture, like auto ordering and how that has been received? Like if you like really, like I think it makes sense for opioids to like order less. People can always like do more, but like has that been something that has been studied, like auto order to do more, essentially, like for like sepsis, like, oh, it's already ordered to have 30 cc's and I have to like unclick it now as like the choice architecture. Is that as much of a thing?
I mean, I think those are like, so it certainly can be very effective. It's just a question of whether it's always indicated in the scenario. I think it's more of an implementation problem, but certainly probably the easiest way to change behavior is you make something the default option so that if they do nothing, they adopt the behavior, but provide a way to opt out. Our health system, a commonly cited one is that there was it used to be like a very hard, like very poor performance in prescribing people generic drugs, and so one bit of software is tweaked where if you put in metoprolol or something like that, it would default to the generic unless you click this box to write it as like whatever the brand name drug it was. And basically like overnight generic prescribing went from like 50% to 100% because of that. And so it's very powerful. You just got to make sure it's nudging in the right direction. Like a nudge in the opposite direction. There's been some studies that showed that removing a default for like opioid tablets for like 20 or 30 pills cause people to like prescribe less because they're getting nudged in a direction that they probably didn't want to go in the first place. So it's however you design the system is going to produce the results that it's designed to do, and so it just helps to be intentional about the design. So I know Jason's presenting at our Nudge Unit Symposium, so that'll be pretty cool. It's good to see you.
Yeah, ours is, your title suggested, more of a shove than a nudge, but it does have a lot to do with getting into providers' workflow and trying to get them to do the right thing. It's super interesting, and the intersection between what your EHR can do and what they'll let you do as to what the right thing is very, very interesting to me.
When is your guys' symposium?
It's not mine, it's kids.
It's online. I think I sent it to you, but
Oh yeah, put it. That's a great thing. Why don't we put it in the chat? Stick around for 1 second. We'll find it and put it in the chat because it's free, right? I'm signed up for it.
I want to sign up. This sounds great.
Yeah, I'll put it in
We'll
the
find
chat. Yeah, I will say, there's a whole like emerging field too now on the implementation science of nudging. Sort of like a lot of nudges and how they're implemented, like really drive the effectiveness of whether really drive the effectiveness of whether it works or not, like how you structure it. So I'm putting this in the chat right now. And this is a symposium of, there's been a lot of attention in our health system towards nudges in healthcare. And so we have an annual conference now. And Jason's going to be one of our speakers, so pretty cool.
Yeah, that's great. And the previous years posted too, so you can watch those. It's like.
Thanks for sharing that link.
Great job, everyone. Thanks for sharing.
Cool, and you can find us online, and I think this is an expanding area, so I was interested in testing things out in different places. So. Like it's
Thanks
definitely
so
emergency medicine's a right field when you think about all the cognitive pressures that are put on us and patients and stuff like that. Brings out the system one thinking. So certainly design around that has a lot of potential. Cool.
Thank you guys all for coming. Please don't hesitate to drop us an email.
Thanks, guys.
Thank you.